When I think of cultural humility, I think of self reflection and the practice of acknowledging both the individual and systemic biases that exist in the healthcare system and how they impact patients.
All right, well, welcome to the Hat Rack. I'm Dr. Bill McCauley. I'm the Associate Dean of Continuing Professional Development and Faculty Development at the Schulich School of Medicine and Dentistry in London, Ontario. And we have an episode that's following up nicely on our last episode in which we heard some information from patients. And the main theme of that conversation was the importance of physicians' ability to communicate with patients. And as I've reflected on my career a little bit, I've been practicing in emergency medicine since 1991. And I would say there are two main things that have changed dramatically since I started practicing. The first is the introduction of intravenous drugs into our culture, which has, for an emerge doc, has been a huge thing. But the second is the diversity in our population, in our patient population, and the number of different cultures that are now part of our everyday lives. And it presents challenges in communication that I think that we don't think enough about, and I think that we don't talk enough about. So today we're going to talk a little bit about cultural communication, cultural safety, cultural humility, and I have two guests with me that are going to really be helpful in helping us to understand this landscape a little bit. So I'm going to ask them to introduce themselves. First, I'll go online first with Dr. Tehseen Ladha, who is with us from Edmonton, Alberta. Tehseen, welcome to the Hat Rack. Can you tell us a little bit about yourself?
Yeah, absolutely. Thanks for having me. So, I am a pediatrician and an associate professor at the University of Alberta. I work in marginalized child health populations, so in refugee health, and I also work in the space of health inequities and medical education. So, really happy to be talking about a subject that I'm really passionate about.
Well, when this topic of cultural communication came up, we started looking, as one does online, for people, and Tehseen's name popped up, and she graciously accepted our invitation to join us. So we're so happy to have you here. And with me in studio is Jannelle Yoon, who works here with us at the CPD office. Can you tell us a little bit about yourself?
Yeah. My name is Jannelle Yoon. Nice to meet you. Thank you for having me here. I am an educational developer here at Schulich School of Medicine and Dentistry and a professor at Fanshawe College.
Great.
Yeah.
So the reason that we are having this conversation today is that one day Jannelle walked into my office and started talking about cultural communication. And she started talking about concepts that I had never heard about. That made sense to me when she started explaining to me. And she was talking to me about high context and low context cultures and communication styles. And Jannelle also works as an interpreter, volunteers as an interpreter. Can you explain a little bit to us what you mean by this concept of high context versus low context?
The high context versus low context cultural uh, concept is, I think, Edward Hall came up with that concept. And what it means is that, for example, a person from low context culture would have an explicit style of communication,
Okay.
direct, and based on what is, like, if it's documentation, what is written is what you would understand and interpret as the communication. But in the high context culture, it would be the opposite. So there is it's implicit, indirect, and there's a lot of reading between the line.
Okay.
Yeah, that type of communication style.
And that communication style would be, so for example, you're a Korean Canadian, and a Korean culture would be a high context
Yes.
society. And so it's less direct. Can you give me an example of what you mean by that? Like if something like indirect communication, if I'm a physician, I'm trying to explain something to you, what would the expectation be of someone from a high context culture?
If, for example, if a bad news is being delivered,
Right.
a patient from a high context culture would much prefer it if it wasn't so direct.
Okay.
Yeah.
Mm.
So using a softer tone would be important. Pauses and silence sometimes would be much appreciated.
Okay.
Yeah. Whereas a person from low context culture might think, just get on with it. Tell me what it is that I have, or,
Right.
that would be a difference.
Okay. Tehseen, have you experienced this as well in terms of dealing with some of your patients, or I guess maybe parents from different cultures?
Yes, definitely. And I think from my perspective, um, it's about trying to pick up on some of those cues that are not verbalized in the high context cultures, um, where there might not be as much direct questioning or responsiveness when I'm talking to them. So I have to look at other cues like body language,
Mm.
rely on maybe family members who have come with them, ask the same questions in multiple different ways, and then really, like Jannelle said, holding space,
Hmm.
pausing, holding space and time for them to verbalize what they may not if I continue to just sort of rush through.
Mhm.
Right. Okay.
Yeah.
Now that sounds like a great approach for anyone, whether they're high context or low context.
Yeah.
For sure.
Why is that more acceptable for or less acceptable for low context communication cultures?
No, I mean, I think it's great for both.
Yeah.
It's definitely great for both. I think the issue um, with the high context cultures is that because they may not be as direct, they may not speak up if they're not given enough time to do so. Whereas the low context cultures, even if you pause for a short amount of time, they will likely get their questions in. They will be direct. They will say, I don't understand, or I need more information. And so then, you know, treating them the same, they'll actually have inequity in their health experience, in their health
Gotcha.
encounter experience. Yeah.
Okay. So from the physician's perspective, it's important to understand the difference between these types of cultures in that a high context culture may not ask the questions in a direct way that someone from a low context culture would. And so you need to understand that that's the case, give them time, give them space, um, and um, and maybe prompt more. Is that would that be the approach?
Yeah, I think so. And we didn't talk about this yet, but many times I think people from high context culture, um, they have great power distance in their culture as well.
Yeah.
So just going off of what Dr. Ladha just mentioned is that patients sometimes don't want to question authority.
Hmm.
Doctors in this case would be authority. And so um, I was talking to Bill actually a couple days ago about one of the assignments that I was in, and the patient had great medical knowledge because he was his in his previous life he was a medical professional, but he did not want to ask any questions before the doctor had give explained everything. So that would be a good example of like seeing power distance, how power distance comes into play
Hmm.
when we are in this kind of communication.
Okay.
Yeah.
We're talking about power difference and power imbalance brings up the concept of cultural safety, I
Hmm.
think. Tehseen, can you help us to understand what people talk about cultural safety and cultural humility? Can you understand help us to understand what these concepts mean?
Yeah, absolutely. So, cultural humility, I would think of as more of the process, and cultural safety as the outcome, but they're very related. And so, when I think of cultural humility, I think of that self reflection and the practice of acknowledging both the individual and systemic biases that exist in the healthcare system and how they impact patients. And cultural safety is the outcome in which you're acknowledging these biases, but then attempting to optimize care of the patients by engendering a trusting relationship, a safe space, and an acknowledgement of their lived experiences. And so, this is distinct from cultural competence, which is sort of an older concept that we used to strive towards, which was on an individual level as health practitioners trying to learn about different cultures and using that information when we had a patient physician relationship or encounter. But that is sort of a more limited definition where it's on an individual level. We're thinking of it as a finite exercise in knowledge attainment versus cultural safety, which is both individual and systemic. It's constant self-reflection about biases that exist, acknowledging power differentials and trying to break them down, and creating that space to engender trust and collaboration to optimize patient care.
Okay. So, would it be fair to say then that if you are practicing cultural humility, the outcome of that then might be the patient feeling safe in that environment, and particularly in those high context cases, high context cultures, if you create a sense of safety, then that will enable those people to be able to be more comfortable and perhaps even more direct in terms of their ability to communicate with you. Does that sound about
Yes.
right? Right.
Yeah, that's right. And by doing so, you're improving their health outcomes because then they can actually divulge their symptoms. They can talk about whether they're not comfortable with a plan, and all of that impacts things like adherence, diagnosis, adherence, treatment, and so on.
Okay. So the outcome is something that happens as a result of the process, and the process is, as you described, cultural humility. So how do we go about doing that?
Yeah, I think that's really important to think about. And I think one thing that I would, if I could speak to all the patient or physicians
Hmm.
listening to this, I would say please be curious
Mhm.
about the patient. Um, I again, um, I spoke to Bill about this a couple days ago, but sometimes it's hard for, I think, physicians to be um, compassionate, actively trying to create safer environment, or where the patient feels more safer in their environment, because, like Dr. Ladha mentioned, sometimes these cultural differences, patients don't want to discuss their pain or, like mental health, because there's stigma.
So creating an environment, a safe environment.
Hmm.
Do you want to build on that, Tehseen?
Yeah, I had the same word written down. Curious,
Hmm.
be curious.
Yeah.
So I think and what I mean from that approach is, be interested in hearing about the patient's lived experiences, not just
Yeah.
their medical care, and
Hmm.
also understand that diverse ideas from patients, diverse lived experiences, these bring strength to healthcare
Yeah.
and health systems. Um, so it's really that appreciation of the person as a whole rather than their
Hmm.
medical symptom or their
Hmm.
diagnosis. And one of the things I've noticed is of course, with this the advent of technology and Google, and you'll see physicians who say things like or feel frustrated because people are Googling their symptoms and then coming in and saying, "I'm
Hmm.
sure I have this," or you
Hmm.
know
Hmm.
could I have that? And so a lot of physicians will say, well, well, we did medical school, like we have the expertise.
Hmm.
And I understand that frustration, but I
Hmm.
also think we really need to check our egos and And, there's good information out there now on the internet. And I mean, there's also misinformation, but there's good information. And patients are able to arm themselves with that knowledge, that information, and able to ask pointed, often relevant questions about their health. And questions that we may not have heard of, that are news to us, but I think should be um, listened to and considered, because we don't always know the answers, and medicine doesn't always know the answers, and we're certainly not always right.
Hmm.
And so I think, an example would be from the this idea of creating safe spaces. Um, my goal would be to be curious when a family says we don't want to vaccinate our children,
Mm.
right? And so I approach that with curiosity, because there have been cases where families have brought to me examples of things that they've read about that I've then researched and have been true.
Hmm.
So I understand where their fear is coming from, and then can address that particular concern in
Hmm.
better detail. So these concerns are valid. They're coming from somewhere, from an experience of someone else, from fear, maybe from misinformation. But asking those questions, being open to hearing those things, and not getting defensive. Like, this
Right.
is my field of expertise. Not letting that ego get in the way of you having an open and collaborative conversation about care. Because ultimately, we're here as guides to medical care. We're not here to decide that for sure that you should be doing this or that, right? That's up to the patient ultimately.
I think that it's likely that we're going to see a transition in terms of the skill set that's expected from physicians
Mm.
in the more traditional model. And physicians from past, people have been admitted to medical school because they're smart and they've got a scientific
Mhm.
background and
Yeah.
they have the ability to have all of this knowledge, but the need to have that knowledge is rapidly
Mhm.
diminishing. And so um, uh, I think it's fair to say that in many medical schools, their admissions criteria have not been strong on the sense of communication skills. But I
Mhm.
think that's likely to change going forward. It has
Mhm.
to change going forward because, as you say, we're
Mhm.
going to be people that are helping to navigate patients through this vast amount of knowledge and the experiences that they're going through. I want to pick
Exactly.
up on a phrase that you mentioned earlier, Tehseen, which was on health inequities related
Mhm.
to different cultures.
Mhm.
So, can you explain what you mean by that? The inequities in health from between different cultures.
Absolutely. So there's definitely evidence in the literature, that various racialized or ethnic groups experience poorer health outcomes or poorer health access because of systemic biases, because of racial bias, because of individual bias. And so, a couple of examples that I often quote when I'm teaching within the medical school. Um, are one local study in Alberta in which First Nations patients were found to be consistently triaged at lower acuity scores in the ERs for the same medical conditions as non Indigenous patients.
Hmm.
This was a
Mhm.
study that just came out, I think, 2 or 3 years ago. And so we know, of course, if you get a lower acuity triage score, that means you're waiting longer to see
Right.
an ER physician, which then means those patients have an increased risk of deteriorating while
Hmm.
waiting. And the authors of that study postulated that part of the issue was likely due to systemic biases as well as communication and cultural communication, the way that the patients were communicating their symptoms and the way that
Mhm.
they were being understood. Um, there's a couple of other examples in pediatrics, for example. If you look at pain management in the ERs, racialized patients consistently get poorer pain management than non-racialized patients. Their pain is not treated as quickly or as comprehensively, regardless of the condition. And even in the U.S., there was a great study at Harvard looking at Black patients' care of heart failure versus white patients. And it found that white patients received more specialized care for heart failure at Harvard than Black patients did. Black patients were often admitted to a more general internal medicine service than a cardiology service. And this was attributed actually partly to Black patients not advocating or not being able to speak up about wanting to have specialized care, maybe because of lack of knowledge, maybe because of cultural differences that they didn't feel comfortable speaking up in those settings. So multiple examples of these inequities in health outcomes, due to a person's ethnic, cultural background, race, or their ability to communicate in the way we often do in this cultural
Right.
environment.
Right, and you didn't mention gender-based differences as well. There are gender-based differences in outcomes too, are there not?
Yes, absolutely, there are. So there was a big study published in JAMA Surgery, and the study took place in Ontario. It looked at over 1 million surgeries, and it actually found that sex discordance in the surgeon impacted female patients. So if a female patient was operated on by a male surgeon, they had an increased risk of morbidity and mortality, actually, than if they were operated on by a female surgeon, whereas male patients had the same outcomes regardless of the gender of their surgeons. So, and again, this study also postulated that females may not feel as comfortable divulging their symptoms, or they may not be listened to by surgeons of the opposite gender. And so, again, communication playing a part in that.
Okay. So I think this has done a good job of sort of setting the stage to help us to understand a little bit about what the problems are and what the reality of these sort of communication styles and what marginalized populations have to experience. I guess we are a podcast that talks about continuing professional development, and so we want to help physicians to be able to change their practice behavior. What can be done? How can physicians learn more about this? How can physicians communicate better with a culturally diverse patient population? Jannelle?
I think one thing I would, again, to the listeners, I would say there is something called healthy immigrant effect. It's a concept that was studied by many. I don't have the details
Yeah.
right now, but what it is that basically immigrants would come to a country in a healthy state,
Mhm.
but because of all the issues that Dr. Ladha just listed, their health deteriorates
Right.
over time.
Yeah.
And that's what healthy immigrant effect means,
I see. Gotcha.
right?
Okay.
Yeah,
All right,
that's
that's
right.
helpful.
Yeah.
Mhm.
Tehseen, have you got some suggestions in terms of what physicians can do to try and address this? Practical
Yeah.
suggestions?
Yeah, I think, from a practical perspective, just introducing into patient encounters phrases like, what parts of the plan do you feel comfortable with or uncomfortable with? Or how do you feel about what we've just talked about? And then implementing those pauses and really being attuned to the body language, the signs that you're getting back, and deciding based on that whether you need to ask the question in different ways or in different medical encounters. And then in terms of resources, I mean, there's so many out there, but the Public Health Agency of Canada does have a framework for things like cultural safety, which is a good toolkit, like a good starting toolkit. And then from there, some of the health authorities, First Nations Health Authority has, I believe, a module on cultural safety, as do some of the provincial health authorities. So those are some good ways to start getting exposing yourself to the concepts and learning about them. But I think practically just integrating that curiosity, those intentional pauses, the repetition of a question in different ways, and that statement, what what about this are you feeling comfortable with? What about this are you feeling uncomfortable with? Um, Sort of, so they're a bit open ended, so they can't just say, oh yes, I'm comfortable, if you say,
Mm-hmm.
are
Mhm.
you comfortable? So a bit
Mm-hmm.
open ended, and also integrating what parts might make you uncomfortable, so that you're opening the conversation up to hearing about not just the positive parts, but the parts the patient is feeling apprehensive about.
Right.
Mm-hmm.
Yeah.
One of the approaches that I've taken is, and it's just a very basic one, is just to try and position myself in that patient's shoes. If
Mm-hmm.
as an emergency physician, we see people from all walks of life, and recently there's been a fair influx of Rohingya patients to the London area, and I, like many physicians, have used Google Translate. And when I first saw my first patient who spoke Rohingya wasn't even in Google Translate, and so you
Mm-hmm.
think, oh, it's just going to take so long. How am I going to be able to communicate with this patient? It's going to be so difficult. It's going to be time consuming. I've got a waiting room full of patients to be seen. And then you think, imagine yourself going someplace where you do not speak a word of that language. You're
Mm-hmm.
an intelligent person. You can't communicate. You can't express what you want to be able to express. You've got concern about your own health or the health of a family member that's with you. And you are there with a frustrated healthcare provider. That is a situation that would be untenable to all of us. And so just
Mm-hmm.
even reminding ourselves of the fact that these people have come from, in many instances, a situation that none of us would want to be in. And they're here hoping that you can help them. And so having a little bit of understanding of that situation, I think, can be important.
Yeah. As an interpreter, I would like to plead that physicians, if you use interpreter, sometimes physicians, some physicians, what they do is they say something and then expect the interpreter to communicate to the patient, and they forget that they're in that conversation as well, and then they go back to their charting. So they turn around from that
Mhm.
situation and they go back to charting, as if this conversation is between just the interpreter
Mhm.
and the patient. And that, I think, is something, if you didn't and you acted as if you were, part of that conversation, I think it makes patients feel much more safer and open to opening up about their
Yeah.
symptoms and so on.
It adds a whole other layer of complexity when you're communicating through an interpreter, because the skills that you might learn or try to practice with respect to cultural humility are much more difficult when you're doing it through someone else
Mhm. Yeah.
who is really really acting on your behalf. Tahseen, what are your experiences with that?
Yeah, I use interpreters a lot in the refugee health clinic here, and unfortunately, it's a phone line interpreter, which is always more difficult.
Mm,
Right.
yeah.
But I agree. I mean, language translation is one thing, but actual
Mm-hmm.
cultural interpretation is a whole other thing, where
That's right.
you're both communicating an
Mm-hmm.
idea and receiving the ideas back. And often what's
Mm-hmm.
happening is just the words are being translated, but you're not getting a
Mm-hmm.
good idea of what's actually going on for the patient or their family. So it can be
Right.
quite a challenge. But I do think that those principles, Bill, like you said, of putting yourself in the person's shoes, and Jannelle, you said earlier, that compassion, those are
Mm-hmm.
key. So, that curiosity, that compassion, that collaborative approach, to
Mm-hmm.
engendering trust, I think go a long way in making an impact, even when those barriers are present.
Mm-hmm.
Great. So we're called the Hat Rack, and the reason we're called the Hat Rack is we like to, as much as possible, give people practical advice and tips on how they can implement change into their practice. Ideally, we like to make it evidence based as well. That's sort of where we try to come from. Jannelle, can you give us one or two things that you would like to take, as you like to call them, our listeners, physicians in practice, to
Yes.
take away from this conversation?
I said this already, but if you are sincere about professional development and you care about your patients and you care about Canadian health care and the outcome of this healthcare, I would like to say, um, be open to educating yourself about not just cultural like competence, but also how to be more empathetic and um, and compassionate. Uh, make yourself, like you said, put yourself in their shoes. Sometimes I've seen a physician where I thought was the best patient physician interaction is this woman who is a female doctor treated the patient as if the patient was her own mom, and she kept on bringing up her own mom as an example,
Mm-hmm.
and the patient felt acted as if the physician is suddenly her own daughter. And I thought that was like, and she opened up, she felt more comfortable, she was smiling more. And I was like, this is amazing. And I think that is a combination of being cultural, having cultural humility, but also compassion and empathy.
Tehseen, do you have some take-home messages for us?
Yeah, I think bias unfortunately has become a word that it elicits a lot of shame, but I just want to like
Mm-hmm.
deconstruct that and say that we all have biases. It's
Yeah.
nothing to be ashamed of, but I think one of the key messages here is that we really reflect on our individual biases and also the systemic biases in our institutions that we're practicing in, um,
Yeah.
within each patient encounter, and ask ourselves, if this patient was of a different positionality, so a different social status or a different ethnic background or a different race, would I be treating them differently than I am now? And I think that's a good check, that
Mm-hmm.
helps us to ensure, that we're creating that culturally safe environment, because oftentimes we are reacting, based on biases and stereotypes,
Yeah.
and it's so automatic. It's that unconscious bias that's hard to
Mm-hmm.
address. And so just reminding ourselves, is this the way I would treat someone else, who with a different positionality in society,
Yeah.
is a good question, I think, to check
Mm-hmm.
ourselves. And then, of course, help us, approaching it with that curiosity to help us engender that trust and that safe space.
Great.
Yeah.
Well, I want to thank you both for joining us today on the Hat Rack. It's been a great conversation, one that's been long overdue, and we appreciate your insights and your experience, both of you.
Yeah. Thank you
Thank
so much for
you.
having us.
Well, I found that to be a fascinating conversation, and what I would take away from it is that, first of all, what strikes me is that a lot of what both Jannelle and Tehseen talked about is communicating with patients in a compassionate way. And I would say that we have to do that for anyone, but our patients are vulnerable. There's always a power differential between physicians and patients. And that power differential is substantially magnified when someone has another inequity because of speaking a different language, or coming from a different culture, or being of different sexual orientation, or being a different gender. And all of those things will magnify the power imbalance. And we need to be mindful of that. I think that's the big take-home message that I took from this is the first step towards trying to deal with those things as a physician is recognize that they're there, so that you can, in a mindful way, practice cultural and patient humility so that you can create a safe space for them and try and minimize those equities.
You've been listening to The Hat Rack, hosted by Dr. Bill McCauley from Continuing Professional Development at Schulich School of Medicine and Dentistry, Western University in London, Ontario, Canada. Technical assistance for The Hat Rack is provided by Patrick Barfoot, Technology Support Specialist at Schulich. Original music was composed by Cameron Beresnick. Please contact us with any questions, comments, or suggestions for future topics or guests. We can be contacted by email at thehatrack@uwo.ca. Additional episode information can be found online at schulich.uwo.ca/CPD.